Hey guys, it's me, Dr. Lindsay, cataract surgeon at Morganton Eye Physicians. I've got a great video I want to show you guys today. This is a patient I treated not too long ago. It's going to show us not just what cataract surgery is, not just what it can offer, but a really extreme example of a cataract and how this can dramatically affect someone's life. So let's get straight to the video. So this is a patient here that unfortunately had not had access to medical care for a while, and he had developed these really extreme cataracts in both eyes. As you can see, this is the cataract right here. So this is the lens in the patient's eye. It has become so cloudy that he cannot see anything. Well, basically anything. It's solid white. I have no view of the retina at all. This patient, when I was testing his vision in my office, he could tell me if the lights in the room were on or off. He could maybe kind of tell me if my hand was moving. He could not tell me if it was moving side to side or up and down, but he could say, well, I see a shadow or something coming over my vision. So, blindness, essentially blindness. And so this patient really needs cataract surgery. And so we took him to surgery, and I want to show you guys this video. So let's start right off here. What I'm about to do is just put a little stabilizing ring on the eye, just to help me hold it in place as I make that. Skip just a little bit here. There we go. Here's the stabilizing ring coming in now. I've got a very small diamond blade here that I'm going to use to create a paracentesis. And this is just an access port. You use this to insert fluids into the eye, anesthetic into the eye, viscoelastic into the eye. So we'll walk through that together. Here we are putting in a little bit of lidocaine. Now this is going to supplement the anesthesia that we've already done. This patient, prior to me coming into the operating room, he's already had what's called a block, which is where my anesthesia team will put a small needle through the patient's lower lid and put some anesthetic behind the eye to anesthetize the nerves back there. And then I supplemented that with some lidocaine inside the eye as well. I then put in a little bit of epinephrine to help stabilize the iris. And here I've actually put in a large air bubble. Some of you guys may know what this is for, but what I'm doing is I'm using that air bubble in preparation to put in what's called trypan blue. That's this dye here. Now normally in most cataract surgeries you don't have to use this sort of dye, but in these more extreme examples where you can't see through the cataract, you don't have a decent light going through the cataract to allow you to see what you're doing, I put in some dye here to help me visualize the capsule. Now what is the capsule? So the capsule is this thin little membrane of tissue that surrounds the cataract. It's extremely thin, especially on the back, as thin as 4 to 5 micrometers or microns. So extraordinarily thin. Anyway, you have to open up that capsule on the top part of it, open it up in a nice circle to gain access to the cataract. Well, if you don't have light coming through the cataract, you can't really see what you're doing. And so I put some dye on there to help me visualize that. And we'll see that here in just a moment. I then rinsed that dye out. I put in some viscoelastic, and now I'm preparing to make the main incision into the eye. This is the incision that we'll use to do the bulk of our work. Our ultrasound probe is going to go through here. We will later insert the lens implant through that incision as well. That incision is made such that it will close on its own. The edges of that incision will seal, and most of the time cataract surgery does not even require any sutures for that reason if you construct your incision properly. So now what we're doing is I'm using a cystotome, which is essentially a needle that's bent on the end. I'm using that to make a tiny little nick into this capsule here, and I'm going to begin tearing it, and we can see that here. Thanks to that dye now we can really see where we're tearing this capsule and where the underlying cataract material is now exposed. It's actually this part of the surgery for these really mature cataracts that can be kind of stressful, anxiety-provoking, whatever you want to call it, because sometimes these cataracts are so large that they're under a lot of tension, and they're pushing with such force on that capsule that the moment you go in there and make that little tiny tear, that pressure just splits the capsule right open. And when that happens, you've got a bigger headache to deal with on your hands. Not the end of the world, certainly, but it is a bit more of a headache to deal with. So we can see here, this actually went really well. Capsule tore very nicely. There were no issues here at all, thankfully. I'm going to pause here. Sometimes if I can tell that it's under a lot of tension, I will make a tiny little incision there and then go through with an empty cannula and aspirate some of the cataract material out just to decompress it a little bit, to relieve some of that pressure before I actually start making the rest of that opening into the capsule itself. Just that decreases the risk somewhat of that capsule wanting to tear on you or run out on you or just go the way you don't want it to go. So now what I'm doing is I'm taking another cannula and I'm going to inject some saline essentially down behind the cataract. And what that's going to do is separate the nucleus, which is the middle of the cataract, the core of the cataract. It's going to separate that from the outer shell of the cataract, which we call the cortex. The reason we do that is because we want to be able to rotate and spin that center material of the cataract to allow us to deconstruct it more easily. And further, leaving a little bit of cortex back there too almost serves as a little buffer to protect that very thin capsule that we were talking about earlier, especially on the backside. And so that's what we're seeing here. If this cataract were not as extreme and we could actually see through it, you would actually see a nice fluid wave go around back behind the cataract. That's how you know you've gotten a nice dissection there of the cataract from the surrounding cortical material. We can't really see that here, so we just kind of have to do it by feel. And then I'll sort of tease the cataract with that cannula to see, do I have a nice spin? Do I have a nice rotation? And we're doing okay there. We had what we wanted. So next I'm inserting the ultrasound probe. We call this the phaco probe. If you've heard me talk about it in clinic, this is the probe I'm talking about when I say an ultrasound will go into your eye. This is what we're talking about. And I'm using this now to begin actually removing some of that cataract material. Ultimately what I'm going to do is create a deep groove into the cataract, and then I'm going to split it apart. We can see that groove beginning to take shape here. I'll skip forward just a little bit. So now we've got a nice groove, and now I'm using my secondary instrument to break that cataract, to split it, to crack it. You may have heard all those terms. We're going to spin it. That's the importance of having a good hydrodissection like we saw earlier. And now I'm going to create another groove, another crack, and ultimately we're going to have 4 quadrants of material here that will very easily come out of the eye like we want. Spinning it again, just doing another crack here. Now we are actually beginning to remove that actual cataract material, and already here at my cursor, hopefully you guys can see the cursor on screen, already we can begin to see through the cataract. Here in a moment you'll get a much better view of that. Here comes quadrant number 2 coming out. This thing is actually very dense. You can't really tell it from this video, but I've got the power cranked up on my machine to get through this cataract. You can kind of see here how these really dense cataracts, instead of being kind of soft and almost gelatinous in a way, I guess, these cataracts can sometimes become very brittle, and they shatter and they fragment almost like glass would. It kind of splinters like that. So here's quadrant number 3 coming out nicely. No issues at all. Let's get quadrant number 4 out of here. There we go. Came out just fine. Now we can really see a nice, beautiful red reflex here. This is the light now coming into the eye, passing through the cornea. There's no lens here, but passing through to the retina now, and we're seeing that red reflex of light back off of the retina. And that's what you want to see. Now this patient's going to get light into his eye. But we're not done. We're not done yet. So now I'm actually taking another handpiece here. This has an irrigation port right here, and an aspiration port, a suction port here. I'm going to use that to suction off the last bit of this cataract material here. This is that cortex material I was telling you guys about earlier. If you leave this in the eye, it's going to cause some inflammation. It's going to be very difficult to control. Patient has to be on steroids for a long time, and you would get a lot of haziness that forms in the back of the capsule here, forming what's called a posterior capsular opacification. Not the end of the world if that happens. If you have to leave a little bit behind because the capsule is just being a little too tenuous or whatever, it's not the end of the world. It just means you're going to have to end up doing a laser treatment sooner to clear up the backside of that capsule. Now most patients will end up needing that laser treatment eventually anyway, but you'd have to do it very quickly after surgery should you leave a lot of material in the eye. But that laser is very quick, it's very simple, literally takes 1 minute, there's no pain, no drops, no nothing. So if a patient needs that, it is not a big deal. You've probably heard me talk about that in pre-op visits with you guys as well. So next, once that is removed, I'm going in to get the last little bit here. I've switched over actually to using a two-handed piece, a bimanual handpiece here. I've got my aspiration port here, my suction, or excuse me, my irrigation port here, my suction or aspiration port here, and I'm using that to get this more difficult to reach cortical material out here under the capsule. We can see this stuff cleared up very nicely. Really cleared up nicely. And so if we compare the red reflex here versus what we had back here, dramatically different. I mean, you can tell patients not seeing much of anything right here. Now they're getting a lot of light into their eye. That's great. But we're still not done. I'm putting in a little more viscoelastic. This is what we use to inflate the eye, give us some structural integrity, to keep everything in place where we want it while we work. So I've got the eye nice and full of viscoelastic. Now what I'm going to do is secure the eye with my second instrument, and this is the lens inserter here. In this particular case, we're using a 3-piece lens. It's made of acrylic. We're going to insert it into the capsular bag. That's the bag that we now have, that the cataract has been removed. We have this nice empty bag to put our new lens implant into, and it's going to sit very nicely inside of there. The lens goes in, it's kind of folded up like a little taco shell. It goes in there, it begins to unfold. I'll then use that instrument to dial the lens into place exactly where I want it, get those nice little, those arms, those haptics into place to hold the lens very securely. Next, what I'm doing is I'm removing the viscoelastic that we just previously inserted. You don't want to leave that stuff in there. The patient's eye pressure will be higher than you want at day one. So we get all that stuff out. And then once that's done, we're getting pretty close to the end. But once we get all the viscoelastic out, we'll make sure our lens is nice and centered. And then next, we will begin to close our incision. Now, this incision is not going to require any stitches. We're just going to use a little bit of saline to hydrate the cornea, make it swell up just a little bit, and that's enough to have those edges of the incision sit down together nicely, and this patient's not going to require any incision or any suture at all. And that is pretty well the end of it there, guys. I'll put a little bit of antibiotic into the eye here. But as we can see here, this patient started with a dense white cataract, essentially blind. Now we have a great looking lens implant, nice clear visual axis. This patient's going to do extremely well. In fact, by a week after surgery, this patient was seeing 20/30 with no glasses at all. And last time I saw him, wasn't that long ago, 3 or 4 weeks ago, he was down to 20/25 with no glasses at all. And so really remarkable result, not even considering where we started, but especially considering where we started, to go from blindness to 20/25 without any glasses correction whatsoever. Really remarkable. And this video shows not just what a cataract is, which it shows that very well, because the anatomy was so abnormal, it allowed us to see the capsule very clearly, the cataract very clearly, the difference between having a nice clear visual axis versus not. But it also showed us just how much cataract surgery can impact someone's quality of life. I mean, this is a 10-minute surgery, sometimes even less, that can really profoundly change someone's life. So I wanted to bring this video to you guys. So that's pretty much the end of it. If you guys want to reach out to me, feel free to do so. Comment below. I'll try to respond to all those that I can. If you or you know of anyone who needs eye care, have a cataract, whatever, reach out to me at my office. I'd be happy to talk to you. I'm happy to see anybody at any time. So I look forward to hearing from you guys. Thanks for watching. Take care.